Next, I want to introduce Dr. Jeffrey Hastings. Now, we have a new TAVR program at the Dallas VA, and I will tell those of you who don't know much about the TAVR program, our nurses, some of our nurses perhaps, and some of our general practitioners, that imaging for TAVR is perhaps one of the most critical aspects to a successful program. And we are very lucky to have a true imaging expert in TEE, three-dimensional echocardiography, and also in multi-directional CT. And that individual, who has been incredibly important for the success of our program, is the physicist and physician, Jeff Hastings. Jeff, would you please enlighten us?
Thank you so much, Jerry. So, thank you, and good afternoon, everybody. It's always a pleasure to be here. What I'm going to talk about today is really the MITRA clip. So, because you're going to hear from Dr. Sirajas shortly after about the details of the MITRA clip. Mine is an easy 10 minutes, probably even shorter than that, because it's going to be a show and tell. So that you can see the images. The transesophageal image is really used to guide the MITRA clip placement. And I know that's hard for the interventionalists who like to use fluoro a lot in some of these cases. But I have no disclosures. So, first, for those who aren't familiar with it, this is what the MITRA clip looks like. The clip itself is on a sheath and wire here that's used to expand it. There is the arms for the clip, and then there are the grippers behind it. So there are two pieces. So the mitral leaflet will fit between these two pieces, gets sandwiched between them, and then the whole clip gets cinched up into a singular piece, so that you can see what it looks like as we go through the echo images here. First, I want to start a little bit with the case. Not really a case presentation, but I just want to prove to you this guy had severe MR. This is a transgastric view, so from inside the stomach. Shows the mitral valve here, and this color, curve is the mitral regurgitation, and it's quite a bit. If we get some other pictures, we can get some from a four-chamber view. We see between the two mitral leaflets, there's some color there. It may be severe, but if we move the angle over a little bit, we can really see that there's a lot of mitral regurgitation. This is a 40-year-old, extremely symptomatic patient. So, an image for PISA for anybody who's interested, but again, this is a PISA radius of 1.5 with a aliasing velocity of 19. This is severe MR, without question here. So we can do some other images. The fancy ultrasound machines now can do something called Xplane. Xplane allows us to see two orthogonal planes at the same time. So we're able to, thank you, Subhash. Am I too close? All right, hope that's better. Maybe not as much echo. We're able to center this through the mitral regurgitation jet between the mitral leaflets, and both here what is a two-chamber view and here a long axis view. So we have anterior, posterior, lateral, and medial here. And we can see this is severe MR. We can repeat that for measuring PISA in 2 dimensions if we wanted to. And this is left upper pulmonary vein. And what's important for mitral regurgitation here, there is systolic reversal in the left upper pulmonary vein, meaning there's such high pressure in early systole that it's forcing blood backwards down the pulmonary vein. So still, as we work this up before we put the clip in, this is what we can see from 3D, and we'll use this quite a bit in the mitral clip imaging. This is looking from the atria down towards the tip of the ventricle. The aortic valve is here at the top, so this is a surgeon's view who's looking down in the chest. He sees the aorta. He sees, behind it the mitral valve. Left atrial appendage is here. Tricuspid valve would be over here. And a little bit of a difference between these two images, part of the technology of the ultrasound machine, this image is taken during 1 beat, and it makes the image. So it's a little bit lower resolution. This image is taken during 4 beats, and so it's higher resolution. Aortic valve up here, we can see more detail of the mitral valve. And this patient who in that transgastric view had mitral regurgitation across the commissure, all the way from one end to the other, you can kind of get a good idea of how that might happen in this patient. At the same time, we can flip that over and look from the bottom side. It's just an interesting picture, but it's upside down. The aortic valve's here. Mitral leaflets, as though we were looking from the apex up into the left atrium. So, what do we do? Did I skip an image? I did. Well, I'm not going to talk much about transeptal puncture, But this is, once you get to the point of transseptal puncture, they put the guide in, pull it, put it up the IVC, pull it down to get to the foramen ovale, and once you're sure you're in the right place, looking at both long and short axes, you end up crossing the septum. Somewhere in here, there's an image that I must have out in order that's a measurement between them. We'll come to it in a moment. But in this view, we can see here's the dilator. It's got a little bit of a screw-type look to it, and behind that is the end of the guide, which has two lines on it that you can tell when you're doing this case in there, so that we know that we've crossed with the dilator and crossed with the guide. Here's the measurement. So before you cross, once you're tenting the septum, so you have your puncture device there, you want to measure between that point of tenting along the line of the ventricle to the plane of the mitral valve. And you want that to be 4 to 5 centimeters. Here we're actually at 3.8. It depends a lot on the patient's anatomy because the catheter has to come into the atrium and then curve down towards the mitral valve, towards the apex. You've got to have enough length to get there, to get that curve made, but not so much length that you can't actually reach the valve in the end. So once we're across, this is the intraatrial septum from the right atrium to the left atrium. We've got the guide across. This is the clip now sticking outside of the guide. It's not open yet. This is what it looks like on fluoro. So here we're extended across. Clip on the end here into the guide. And then just so you can see it on fluoro before we look at it on echo, when they open the arms up, this is what we see.
Jeff, step in closer to the microphone.
Yeah, okay. And then on echo, with the arms open, as I showed that picture before, we can see here are the arms, and here are the little grippers that have the teeth on them, where the mitral leaflets will fall in between those spaces. So once it's open, we have to get it into the right position. And this is really where it starts to get more complicated because you're trying to get it in the middle of the regurgitant jet and trying to get it pointed towards the apex. And the controlling box for this is fairly complicated. You know, I'm just doing the TE images, so it's the same machine we always use, but Manos is the one who's having to make all the adjustments on the box, get it to bend different ways and get it pointed the right direction. But we end up using a long axis view where we have the LV outflow tract here. We have an anterior and posterior wall, and we have a two-chamber view, which is going to have a lateral and medial wall here. It's a bicommissural view. So trying to get it into the middle of the jet. So here we can see the color jet in the bicommissural view. And we're close. You really want to bisect that jet, so you'd like a little bit of mitral regurgitation going on both sides of the clip. So we would move that over a little bit. And then you also want to get it turned correctly. Once you open it, you need to get it perpendicular to the line of the commissure. And this gets a little more complicated. So here we can see, again, the surgical view, aortic valve, mitral valve here, and here is our clip with the arms open. So that's the commissure. And wherever we need to be, whether it's, this is lateral, so A1, P1, A2, P2, A3, P3, we need to be perpendicular to that line of the commissure. So if we're there, we need to be lined that way. Or if we're on the far right side, then we need to be turned counterclockwise. So we use this view to make sure we get it turned so it's perpendicular. We go back and forth through these views multiple times from the long axis bicommissural 3D to make sure everything is lined up in the right place. Eventually narrow down into the right position. Cross into the ventricle, often recheck position again, and start to pull up against the leaflets. Here we can see the arms are open, mitral leaflets. Here we've captured. At this point, actually, we've pulled up and closed the clip on the leaflets, and we have some MR still, not as much as I showed you before. I'll tell you this case. We had a lot of discussion at the end of this. Were we done with this? Did we need to do a little more? We looked from the stomach here, this transgastric view. Here we can see the clip. We can see the mitral opening on both sides. So we have a smaller one and a larger one. So it's a good capture. It's not quite in the jet where we want it to be. This is actually an image of a different patient, but 3D from above. Again, to orient you, aortic valve is here, mitral valve is here. There's the clip, causes a tissue bridge from the anterior to posterior side, and we end up with the openings of the mitral valve. And it should look like a little bit like a bow tie and not like a figure 8. So this one looks like it should. When we do these clips, we do worry about transferring, the problem of mitral regurgitation into mitral stenosis, because you end up narrowing the valve orifice as you put these clips can be multiple clips in. So here we measure the gradient in this patient, we get a gradient of 3, so we're actually okay. Measure the left upper pulmonary vein, the systolic reversal is gone, so it's improved, but we still aren't happy with the result. So in the end, we decided to put in a second clip. Just to show it on fluoro, an image 3D from above, the original clip here, second clip comes in next to it. We need to actually rotate it counterclockwise because to line up, now we've got to line up with the clip, but still try to be perpendicular to the commissure line. And here's our patient with the second clip in. So less MR. Here's the left upper pulmonary vein. Systolic reversal is gone, so it's a different pattern. And the last thing that I want to leave you with is it's always interesting doing cases with Manos and Subash because you find things all the time that are surprising. So this was that MitraClip case that is part of why the case took us so long, because we found this right when we started the case. So this is the aorta, for those who aren't familiar with this, aortic valve. This would be the right coronary artery, and there's something sticking out of the right coronary artery. That's not normal, it shouldn't be there. It turns out this was a stent that had been placed over a year ago. Patient had been cath sensed at an outside hospital. The stent had been pulled and extended into the aorta. So we had a lot of discussion of what to do at this time. Whether to proceed with the MitraClip or not, we ended up proceeding. The patient had been on anti-platelet agents, and we're going to continue those, hadn't had any problems, had had a lot of discussions with Chip Huffman and Mike Jessen about whether or not this needs to be removed, and still some discussion about it. But patient right now is doing well. So my thanks is for Manos, because without Manos, I wouldn't be able to have this clinical experience of doing the MitraClip imaging. So I really appreciate that, giving me some time in the lab. So thank you.